Everyone, thank you for joining us for tonight. It's our pleasure to have you with us. This is Balsam Al-Anani. I'm the cardiovascular metabolic product manager based in Jordan, and I will be talking on behalf of Dar al-Dawa. As you know, Dar al-Dawa is always committed to provide the best quality medications as to meet HCPs and patients' needs across the region. Therefore, today's event will be a huge milestone in Dar al-Dawa journey. This event will be launching the first generic Rivaroxaban in both countries, Jordan and Iraq. And we will be hosting specialists from both Jordan and Iraq. And our shining stars for today's event are globally elite and well-reputed cardiologists. And of course, with collaboration with the ICC, let me introduce you to our moderator for tonight, Dr. Mahmoud izzraiq, a consultant interventional cardiologist from Jordan. Please, Dr. izzraiq, allow me to initiate this evening with 3 minutes of classical music played live by the talented Jordanian pianist Rita Abu Krayem, and this will be resembling Zarlan theme, Orchestrate the Cascade, which refers to the HCP's role in managing and conducting the coagulation cascade. So please join me to welcome Rita. Rita, please, the stage is yours.
Hello.
Hi, Rita.
Can you hear me?
Yes, we can hear you.
Okay, my name is Rita Abu Krayem, and I'm here to perform a part of Beethoven's Piano Concerto No. 3 in C minor. I'm going to play the cadenza, which is the solo part.
Thank you.
Thank you, Rita.
Thank you.
Okay, hello everybody. We have two parts today. First part will be with Professor Verma. The second part will be discussion in interventional cases. I would like to introduce first of all Dr. Hisham. He is from Palestine, interventional cardiologist, and Dr. Hadi Abu Hantaj from Jordan. He is consultant interventional cardiologist. And we have here today Dr. Subodh Verma is an internationally renowned cardiac surgeon, scientist, and professor at the University of Toronto. He is the Canada Research Chair in Cardiovascular Surgery and the past recipient of the Howard Morgan Award for Distinguished Achievements in Cardiovascular Research and the Royal College of Physicians and Surgeons of Canada Gold Medal in Surgery. He served as Canada Research Chair in atherosclerosis for 10 years, from 2007 to 2017. Welcome, Dr. Verma, and the stage is yours.
Wonderful. So thank you, Dr. Mahmoud, and thank you, Balsam, and colleagues, and Dr. Hadi, Dr. Hisham, and Rita. What a wonderful way to start today's program. I've never actually been part of a CME lecture where you get to break the ice in such a wonderful way, and congratulations to you. And I think this was a great idea of Balsam to actually, get us all sort of in the right mood for this. So, and also congratulations to you on generic Rivaroxaban being launched. I think this is a big milestone, particularly, and I do hope that it comes at a cost that makes life a bit more affordable for the vast majority of people, because that is the Achilles heel of getting therapy in the hands of the patients.
Exactly.
So I would like to very briefly review with all of you the data that many of you already know. This is the remarkable story of Rivaroxaban. I've spent a lot of my life doing clinical trials, and I have to tell you that this has been an incredible journey of investment in science, investment in the future of not just stroke prevention, but also vascular protection. So do we have the answers to every single question? Maybe not, but we certainly have moved the field significantly to improve the outcomes for millions of patients with cardiovascular disease, for stroke prevention, and also for secondary prevention. As you know, with the Compass regimen now, a new day in how we think about secondary vascular protection. So we're going to spend a bit of time just reminding you all about the results for stroke prevention, and then the results for vascular protection in the form of the Rocket AF, the Pioneer PCI, and the Compass trials. And this is just to set the stage for some discussion later on, but also to remind you about the overall gravitas of Rivaroxaban as it relates to this very broad bandwidth that it has, from sort of secondary prevention all the way to stroke prevention and AF. I think this distinguished audience appreciates the fact that the burden of atrial fibrillation-related stroke is significant. AF increases the risk of stroke by up to 3 to 5 times. It increases the stroke severity significantly. The 30-day mortality rate of an AF-related stroke is significantly higher. The 6-month mortality rate is about 37%, as you see here. So it's associated with longer hospital stays. And interestingly, as you see in the pink, that AF-related strokes seem to have a higher 1-year recurrence rate compared to non-AF-related strokes. The disability of AF-related strokes persist over time, and these are data from the Framingham Heart Study that have evaluated the acute phase, 3 months, 6 months, and 12 months. And you can see that the AF-related disability score, i.e. severe disability in the proportion of patients that had a stroke, was higher in those with atrial fibrillation compared to those without AF. Again, very quickly to remind you about the importance of anticoagulation for stroke prevention and atrial fibrillation. This audience requires very limited review of this. These are the cumulative data for warfarin versus either placebo or control. And as you know, this is a therapy that reduces significant stroke-related events or systemic embolization, and that effect has been seen consistently. The reason why we have these new strategies in the guidelines that are preferred, whether it's Rivaroxaban or the other 10A or DTIs, is primarily because, as you know, warfarin suffers from this very narrow therapeutic window, and getting people within this therapeutic window remains the Achilles heel. If you're too high, you know what happens. If you're too low, you know what happens. And it's a sweet spot that some can hit and the vast majority can't. And that is shown here, that no matter where you live in the world, US, Canada, France, Italy, Spain, the real control remains a problem. So the slide that you need to look at here is the light blue, that the INR in 2 to 3 range is sort of seen in about 40, maybe 50% of patients, but the other 50% are either subtherapeutic or supratherapeutic, and therefore are at risk of ischemia or bleeding, respectively. This concept is further illustrated here, that anticoagulation in patients with AF has historically been suboptimal. You see on your left are pre-admission medications in patients at high risk for atrial fibrillation admitted for the first ischemic stroke. About 600 patients, 29% were not on any antithrombotics, about 30% were subtherapeutic on warfarin, 10% were therapeutic, 30% were on single antiplatelet strategies, and 2% were on DAPT. So, we have great tools, but the penetration of these tools into clinical care has been suboptimal. Likewise, a similar statistic exists on the right with respect to patients with readmission following a stroke. So just to summarize then, as you know, vitamin K antagonists are effective at reducing stroke risk by 2/3 in patients with AF, but are associated with many limitations. VKAs also have significant variability in the response and a narrow therapeutic window, leaving patients at risk of stroke or risk of bleeding. And anticoagulation in routine practice is suboptimal, and many patients have INR outside of the therapeutic range. Now, how do we assess risk in AF? Again, for the cardiologists on the line, this is just a reminder of the CHADS-2 score and the CHADS-2 VAS score. I think all of you are highly familiar with this. Just again to remind you that CHADS-2 VAS also incorporates the presence of vascular disease, age over 65 to 74, female, gender, and therefore the CHADS-2 VAS score is out of 9 points and the CHADS-2 score is out of 6. Remember, the highest weighting is given to a prior stroke, TIA, or thromboembolic event. And on your right of this slide is a reminder that as the CHADS-2 score increases, so does the risk of stroke without treatment. Therefore, there has been some suggestion about whether CHADS-2 0 needs to be anticoagulated or not, and that's something we'll discuss during the Q&A. Now that's the efficacy side of risk stratification, but what about the bleeding side? And this is the has bled score. And again, as most of you are aware, the has bled score, H stands for hypertension, A stands for abnormal renal function, another A for abnormal liver function, S for stroke in the past, B for major bleeding or predisposition to bleeding, labile INRs, elderly patients, those who are taking drugs that increase risk of bleeding, such as other antiplatelet strategies or NSAIDs, or concomitant alcohol intake of more than 8 drinks per week. And this is again a numeric score out of 9. As you see on your right, low, moderate, and high risk is defined as those that have a score of 0, 1 to 2, or more than 3. And that is something that we take into the sort of overall calculus of determining efficacy and safety when using anticoagulant strategies. I'm from Canada and we follow the CCS algorithm. We're simple people in Canada. We don't like complicated diagrams or complicated pathways. And therefore I love presenting this slide because it's simple. And that is, you have a patient with non-valvular atrial fibrillation who actually is age over 65. You give an oral anticoagulant, period. And you see that there's a asterisk there, and that asterisk is that if you're going to use an OAC, then you should use a NOAC, and that should be the preference over warfarin. So the days of warfarin, of course, have long passed. Now, if that's not the case and someone has had a prior stroke, hypertension, heart failure, or diabetes, then you should still give a NOAC, and that should be your preferred route. And if none of that is the case and you just have coronary disease or PAD, then you should give antiplatelet therapy. And there's a hashtag here, and that hashtag is choose antiplatelet therapy, which is either single, double antiplatelet therapy, or dual pathway inhibition with, low dose Rivaroxaban and aspirin. And if none of that applies, then give no antithrombotic. So I think this is a very simple algorithm. And the question is not who should be treated, who should not be treated. The vast majority of patients are candidates. And in this case, for low-dose Rivaroxaban, if they have coronary disease or PAD, or 15 or 20 milligrams of regular Rivaroxaban, depending on whether they have renal disease or not. So let's just remind everybody about the NOACs, or the non-vitamin K oral anticoagulants. You know that there's 2 varieties, the 10A inhibitors, Rivaroxaban, apixaban, edoxaban, betrixaban, and as Dr. Balsam has just mentioned, Riva generic is being introduced in the market now, or will be introduced in the near future. And then, of course, there's the direct factor 2A inhibitors, which is dabigatran, and that is listed in this slide here. Why do we prefer these, and why do guidelines throughout the world prefer NOACs over vitamin K antagonists? For many reasons that you've heard repeatedly, fast onset, predictable anticoagulation, reduced potential for food and drug interactions, simplified fixed dosing regimen, no need for routine coagulation monitoring, and all of these things together make life less labor intensive, make life less, better for patients overall in terms of quality of life, and most importantly, improve compliance in the time that these patients are exposed to, either a bleeding or an ischemic risk is minimized. Now, many agents are available, and I really think that we do a disservice by too much over comparison of one versus the other. That becomes more of a marketing sort of strategy, and it's less scientific. And I think we lose credibility as a group of physicians and leaders when we start becoming marketers. So I think we have to be very, very respectful of the evidence and really embrace it as the tremendous privilege we have. And I think collectively, all of them have displaced warfarin, and there should really be no warfarin used except for, the certain sort of specific instances for valvular patients, or maybe those with antiphospholipid syndrome, or things of that sort we can discuss. And I then think that the priority should be given to strategies that are easily accessible to people, that are cheap and inexpensive. And I think in that regard, I think the fact that Riva is coming to the market as a generic, I think is a great opportunity for patients, as long as it is manufactured with the same sort of kinetic and dynamic, checkpoints, and is relatively inexpensive compared to the branded product. Then I think that's a wonderful advance for patients. And so I don't think that one is better than the other per se, and I don't think that's how we should practice. But I am a big fan of Rivaroxaban because I've been involved in the clinical trial program. We just published something from Compass Diabetes. So if I get too enthusiastic about it, please remember that I've been involved in these trials, and therefore I'm a big supporter of Rivaroxaban. Now, one of the characteristics that often comes up, as you know, is that it has the shortest half-life. And, although it has the short half-life, it is given once a day. And again, that's just noise from competitors, right? Saying, well, maybe it's not good. Maybe it should be given twice a day. Maybe that's what, and those are just ridiculous kinds of comments. It's given once a day. It was tested appropriately once a day. Sure, the elimination half-life is short, but the pharmacodynamic effect persists beyond the elimination half-life. And that has been very clearly described in the phase 2 sort of evaluation of the program. And, you can't seem to win. If you give something as an advance to people once a day that improves compliance, people worry maybe you should give it twice a day. If you give it twice a day, they say, no, it's not good. Give it once a day. Once a day has been tested. It's safe. It's used in millions and millions of patients worldwide. And we don't want to go back to the drawing board and make life more complicated at this point in time. The other beauty of the trials is the breadth of the severity of the risk that has been evaluated. So you see Aristotle, Rely, Engage AF, and Rocket AF. And what you see here is that there is a great range of the overall CHAD score seen across these various groups, such that in the Rocket AF trial, 87% of patients had a CHAD-2 score of over 3. And again, that is an important message that Rivaroxaban has been tested and demonstrated to be safe and efficacious and superior with respect to its various outcomes in the sickest of the sick patients with the high CHAD-2 score. And I think that's a very important observation. If you can fly a 747, I think you can fly a small propeller plane. So it tells you about the strength and the robustness of the strategy across the agent. Now, there are some differences between the trials with respect to non-inferiority, superiority, etc. Direct comparisons are very difficult to do between trials. As you know, in the Rocket AF, the main study results demonstrated clear non-inferiority with a p-value of less than 0.001 against Warfarin, and superiority when it came to the bleeding outcome. The other attributes are discussed in the next slide. Let me just skip over this and talk a bit about the consistency of the data for the reduction in stroke and systemic embolization. And you can see very consistent data versus Warfarin with respect to reduction in stroke and systemic embolization with Riva, dabigatran, edoxaban, and apixaban. And shown here are now the data with respect to intracranial hemorrhage. We don't see a lot of them, but once you see one, you're scared of it for the rest of your life. And that is, a Warfarin-induced intracranial bleed. And shown here, for example, is the data with respect to Rivaroxaban, dabigatran, Engage with edoxaban and apixaban, and you see a very consistent and profound superiority of NOACs over vitamin K antagonists for this outcome. And shown here are fatal bleeds. and the fatal bleeding outcome is also, markedly reduced with this strategy. At the end of the day, you're either here or you're there, and all-cause mortality trumps everything. And what we see here is that the point estimate for all-cause mortality favors NOACs for all of these strategies versus vitamin K antagonists. So now moving along, let's look at the clinical outcomes with NOACs in high-risk real-world patients with prior stroke and TIA. And this is where there is, real-world data are valuable for extrinsic validity. Oftentimes they're used for, understanding generalizability of the data. And what you see here is Riva versus Warfarin for the endpoint of ischemic stroke, ICH, or major bleed. Again, you see a point estimate of 0.48 for ischemic stroke, favoring Riva versus Warfarin, a point estimate of 0.40, favoring Riva versus Warfarin. And, likewise, there's favorable effects of apixaban and dabigatran, but numerically, at least in this real-world analyses, Riva seems to be the one that has a greater numeric reduction. There has been a observational single-arm cohort study called Xanthus, and that was done with the objective to collect real-life data on the AEs, bleeding, thromboembolic events, and mortality in people with non-valvular atrial fibrillation treated with Rivaroxaban. This was about 6,000 patients in Europe and Canada who started treatment with Riva to prevent stroke or non-CNS systemic embolization. Primary outcome was major bleeds and AEs and all-cause mortality, and we had some secondary outcomes that related to thromboembolic events, non-major bleeds, treatment satisfaction, healthcare resource utilization, etc. And essentially, this confirms a generalizable result in a large number of people from Canada and the US that the major outcomes on Rivaroxaban in the real world are consistent with the results from the landmark or registration trial, ROCKET-AF. Now, the dosing is also a topic of intense discussion, not debate, but just discussion, because many patients with AF, as you know, have renal disease. And specifically because today we are talking about Rivaroxaban and its local generic launch, just to remind you that Riva can be given down to a creatinine clearance or GFR of 15 with some dose adjustment. And that is shown here in the left upper corner of the slide, that for individuals with a GFR or creatinine clearance estimated of over 50, you just stick with the 20 milligram once a day dose. And for people with a creatinine clearance between 15 and 49, you get 15 milligrams once a day. And for the other agents, the algorithm is a little bit more complicated. And you can see here that for dabigatran in less than 30, it's contraindicated. For edoxaban in less than 30, it's also contraindicated. And for apixaban in 15 and above, it says use with caution. And in those that have a GFR above 30, there's an algorithm that takes into account the age, the weight, and the serum creatinine. And there's a complex permutation to use either 2.5 milligrams BID or 5 milligrams BID. So the Canadian product Monograph, and of course, please forgive me, I don't have your local product Monograph, so I'm just sharing you what I think is a reasonable and potentially global sort of footprint of the overall product Monograph. What you see here is that in people with severe renal disease, 15 to less than 30. So that you see the various doses listed here for prevention of VTE, treatment of VT and prevention of recurrent DVT and PE, and then our regular sort of vascular protection dose of 2.5 milligrams BID with aspirin. And as you know, less than 15 Xarelto, which is the trade name, or Rivaroxaban is not indicated. By the way, what is, Dr. Balsam, what is the generic name of your drug in the region? You're muted, yeah.
Yeah, sorry. It's Zarlan.
How do you spell it?
Z-A-R-L-A-N. Zarlan.
Oh, Z-A-R-L-A-N?
Not an X. Yes.
Zarlan, okay.
Zarlan, yes.
So Zarlan. And, you know, just moving along that, that thesis, you know that renal impairment is important, and having tools and strategies in people with renal disease is quite valuable, particularly as we can see here that every third patient with AF has CKD, and the fact that we have the option of a lower dose of Rivaroxaban in these patients is quite valuable. Now, you may wonder, where did this evidence base come from? And the Rocket AF trial versus Aristotle or Engage AF or Rely, the proportion of patients with moderate renal impairment was, you know, 21% in Rocket AF, but the number of patients on reduced dose with moderate renal impairment was about 20.7%, and therefore it's a pretty good number of individuals to base this decision on. Now, moving along, and maybe just to make a little bit of time up, let's get into the next section, which is people who are elderly, a growing group of patients worldwide at risk of AFib, at risk of heart failure, and at risk of bleeding. And when you look at net clinical outcomes with various NOACs versus Warfarin in elderly patients defined as people over the age of 75 with atrial fibrillation, you see the point estimate for Riva versus Warfarin, dabigatran, or apixaban are all listed here, 0.58, 0.73, and 0.73 respectively. Really no statistical heterogeneity per se with respect to the p-value. Numerically seems to be better with Riva compared to the other agents. Again, great safety and efficacy of Riva in patients with frail elderly individuals. In the light blue, you see the point estimate for systemic embolization and ischemic stroke in people who were treated with Riva versus either Warfarin or placebo. Now we start getting into the concomitant coronary artery disease population, which is exceedingly common, as you know, AFib with underlying coronary disease. And we have many of our esteemed chairmen today are interventional cardiologists. And you know, according to various guidelines, this is one snapshot of the simplified version of the Canadian guidelines for patients with AF with an indication for stable CAD or PAD. If they're under 65 and have a CHADS of 0, then we have said really no antithrombotic therapy is recommended in that strategy. If they're under the age of 65 and a CHADS of 0, have stable CAD and vascular disease, then they should get antiplatelet therapy. And in this case, we would say the use of aspirin and the use of aspirin plus dual pathway inhibition, low-dose Rivaroxaban, particularly if they have polyvascular disease, or dual antiplatelet therapy if they meet the criteria and have had recent stenting, for example, or a non-STEMI. And here on your right are people who actually have age over 65, a CHADS 2 score over 1, have stable CAD or vascular disease, we say OAC alone, and that is being revised in the guideline update that we are soon to put out. So now moving forward with respect to risk of myocardial infarction in patients taking NOAC versus Warfarin in the phase 3 trials. And, you know, dabigatran was a bit of an outlier here, controversial discussion around it. The rest have been relatively neutral with respect to this outcome. I was just chatting with Dr. Mahmoud before we got started about the Pioneer AF-PCI study. I think, you know, study that many of us look at with great enthusiasm because it applies to many of our patients. First of all, don't start going into the weeds of Pioneer AF with respect to efficacy, because the trial was powered for safety and bleeding, and that's the primary outcome. So as you know, there was a smallish study, 100 patients with non-valvular atrial fibrillation, undergoing coronary stenting, no prior stroke TIA, randomized, after sheath removal in less than 72 hours to Rivaroxaban 15 milligrams once a day. It was dosed at 10 milligrams once a day in people with a creatinine clearance of 30 to 50. The other strata was Rivaroxaban 2.5 milligrams BID, clopidogrel 75 milligrams daily, and aspirin. And then that was after 12 months, really converted into Riva 15 or aspirin 75, the Atlas-like protocol. The first one is the WOST-like regimen. And then the triple therapy that we all quite dislike as the other standard here, and that is Warfarin, clopidogrel, and aspirin. And what you see here is that for the primary endpoint, which was, looking at the bleeding endpoint, both Rivaroxaban strategies were associated with a significant reduction in the primary bleeding endpoint. So just to remind you, in the first strata, which is Riva 15 plus single antiplatelet agent versus, Warfarin plus dual antiplatelet therapy, the hazard ratio was 0.59, highly statistically significant, p-value less than 0.001, absolute risk reduction of, in both cases, of close to 10%, absolute risk reduction. The Rivaroxaban 2.5 BID plus DAPT versus Warfarin plus DAPT had a hazard ratio of 0.63, again, highly statistically significant, great absolute risk reduction. So I think from a safety standpoint, this has really sent home a very important message. Now, sure, efficacy wasn't powered for efficacy, and we did not see marked changes in that regard. Rehospitalizations due to CV events and bleeding were both reduced with Riva treatment strategies, as shown here, both with respect to either low-dose Riva and DAPT or 15 milligrams and one single antiplatelet strategy. So based on that, what has been our algorithm for managing AF patients with ACS and or PCI and an indication for an oral anticoagulant? It's a complicated slide, so let's go through this with the blue box at the top left-hand corner. If a patient is scheduled for elective PCI without high-risk features for a thrombotic CV event, then dual therapy that involves an oral anticoagulant and clopidogrel is appropriate, with a duration of 1 to 12 months post bare metal stents and 3 to 12 months post drug-eluting stent. Now you can see at the very bottom, stable CAD and PAD now have an indication for, dual pathway inhibition, and I'm not sure if that's the case in your region, but certainly is the case in Canada and the United States. The second box is an ACS with PCI or an elective PCI with high-risk features for thrombotic CV events, and in that case, the suggestion is short-term triple therapy, oral anticoagulant, aspirin, clopidogrel potentially, but quickly converting to dual therapy, including an oral anticoagulant and clopidogrel. And then finally, in ACS without PCI, dual therapy of an oral anticoagulant and clopidogrel for a duration up to 12 months post-ACS. And then there's the conversion of how you convert these people from 12 months to who are on dual antiplatelet therapy in many cases to a vascular protective dose of Rivaroxaban. So practical management issues are often things that cardiologists and family docs ask about is how do I discontinue and how quickly do I discontinue? And on the left is the guidance for Rivaroxaban, Apixaban, and Edoxaban. Determine the patient's risk of bleeding. If you're at low risk of major bleeding, stop for 1 to 2 days. If you're intermediate or high risk of major bleeding, 2 to 3 days. Now, moving along, we see the bleeding risks for various invasive surgical strategies that are shown here. I think all of you are quite familiar with the high-risk ones are neurosurgery, cardiac surgery, major vascular surgery, etc. Abdominal, intrathoracic, orthopedic are usually intermediate, and then, you know, the low to very low are everything else. You know, going to see your dermatologist or a gastroscopy or dental extraction, cataract removal. These are ones that are not ones where you need to necessarily even withhold therapy for any significant time. I want to be respectful of the time and just leave a bit of time for discussion, but what about switching between warfarin and NOACs? And you know that warfarin to a NOAC, you discontinue the warfarin, check INR, initiate Riva if or edoxaban when the INR is less than 2.5. You initiate dabigatran or apixaban when the INR is less than 2. On the other hand, how do you move from a NOAC to warfarin? And in this case, rivaroxaban, apixaban, edoxaban should be continued concurrently with warfarin until the INR is more than 2, and then discontinue rivaroxaban, apixaban, or edoxaban once the INR is greater than 2. And I'm sure all of you are quite familiar with this algorithm. There was a very interesting study, Navigate ESUS, and you know, this is the embolic stroke of undetermined source. This was a study in which patients with the recent ESUS were randomized 1-to-1 to rivaroxaban or aspirin. And if you looked at the primary outcome, there was really no difference, but there's some hints and suggestions of benefit in subgroup analyses of people with a patent foraminovaly, as shown here, or even in those with an enlarged left atrium of more than 4.6 centimeters. So if you do have an ESUS and you have a PFO or you have someone with a dilated atrium, then I think it's highly reasonable to be considering this strategy. So in the last 5 minutes, let's very quickly talk about the COMPASS trial, which I think is a game changer in the way we think about vascular protection. It's taken us from aspirin to aspirin plus low-dose rivaroxaban and shown profound effects on mortality. The trial was stopped early for overwhelming benefit for mortality. And it was also associated with tremendous net clinical benefit and a major reduction in amputation. So these were stable patients without AF who had chronic CAD or PAD, randomized to rivaroxaban 5 milligrams BID or 2.5 BID and aspirin, low dose or aspirin alone. And you know the main results here, and they were quite remarkable. The study was stopped over, just over 22 months by the DSMB for overwhelming efficacy. And the benefit was driven by a 24% highly statistically significant reduction in the 3-point MACE. There was a 22% reduction in CV death. Not listed here is that there's an 18% reduction in all-cause mortality in the low-dose rivaroxaban plus aspirin group. There's a 42% reduction in the incidence of stroke. Like, holy crow, that's unbelievable. And the risk of myocardial infarction was reduced numerically by 14%. And the Kaplan-Meier curves are shown here. Now, I would like to remind you that all types of strokes were reduced, included ESUS and cardioembolic strokes. And this has just been published in JAMA Neurology just very, very recently, that it's not just cardioembolic, but you can see that the other types of strokes are also reduced markedly with low-dose rivaroxaban and aspirin. Now, there was a price to pay, and that there was an excess risk of major bleeding, and that is shown here. The bleeding was not fatal. It wasn't intracranial. It was mostly front-loaded within the first year, and it was mostly gastrointestinal. And this was published by Dr. Eichelboom last year, that the vast majority of bleeds were gastrointestinal in nature, as opposed to, intracranial, fatal, or other types of bleeds. Now, I would like to make the point that this bleeding seemed to actually be front-loaded. On the top here are the MACE benefits, and you see the MACE benefits are consistent in the first year, 1 to 2 years, and more than 2 years. But at the bottom are the bleeding effects, and the bleeding benefits seem to be front-loaded. In the first year, there's a 2.3 times higher risk of bleeding, but beyond that, the bleeding risk is not that high. So it's like your stress test. You know, if you get through the first year just like that, you're good. You're good to go. And but the efficacy seems to be maintained. Now, just last year in Circulation, there was the sub-analyses looking at the cancer diagnosis after bleeding. You know, when people get a low dose of Rivaroxaban and aspirin, and if they have a GI or a GU bleed, that should tell you that there's probably occult cancer that you're missing. The hazard ratio, that's not a spelling error, it's 20.6. 20.6 is the hazard ratio for a gastrointestinal bleed associated with a hazard of cancer. And on the right, the hazard ratio is 32.5 for a genitourinary bleed and the association with a genitourinary cancer. So I'm less worried about 2.5 BID of Rivaroxaban causing bleeding. Like, again, give me a break. How many times have you sent someone on 20 milligrams of Rivaroxaban to endoscopy? We don't see that often. And at 2.5, I have not seen a bleed yet. But if you do see a bleed, think about genitourinary and gastrointestinal cancer. So, you know, our chairman him and I were chatting about this a few minutes ago about how do you do the math of net clinical benefit. And what we've tried to do here in this paper that was recently published is look at the absolute effects at 30 months according to baseline risk. And what you see is if you apply a REACH risk score and you go from left to right with Rivaroxaban, you see that overall in the average trial population, you would prevent 23 MACE events or acute limb ischemia or amputation events per 1,000 patient years. And that would come at a cost of 2 excess bleeding risks. But as the patient's risk level is higher, even higher, you see that the top number increases, but the severe bleeding risk did not increase substantially. So just to remind you that efficacy results are higher as risk level increases, and bleeding seems to be consistent across that cohort. And that's shown in this slide. So when you put this strategy head-to-head in indirect comparisons to ACE inhibitors, lipid lowering, DAP, blood pressure lowering, you know, this is a game changer, period. It's a new day for vascular protection for patients with, you know, CAD and PAD. Now, what I did not mention to you was here, male. I haven't discussed that, but, you know, prevention of limb loss is a very important outcome. The worst thing that I did when I was training, and that's why I became a cardiac surgeon and not a vascular surgeon, was it's disgusting to perform amputations as a surgeon. It's disgusting outcome for patients. And it's one of the most morbid things that we need to prevent. And if you can prevent loss of limbs, it's sometimes even more than preventing death for a patient. And this is a profound intervention, cutting the risk of amputation and major limb loss by 46% with this strategy. If you have a patient with PAD, that patient needs to be on this strategy. To sum this up and to really hit this home, my good friend Mark Bonaca just published this study on VOYAGER PAD to look at people that have been revascularized following PAD. And they found that this low-dose Rivaroxaban and aspirin regimen was highly efficacious even in those patients with a recent peripheral revasc. So, you know, there's patients with stable CAD in COMPASS, and there's the COMPASS PCI regimen, then there's the patient with PAD, and then there's the VOYAGER PAD with recent revasc, and that's the vascular protection bucket of this story. Now, with Deepak Bhatt, I was involved in this publication that we just put out looking at COMPASS diabetes, and we found that in people with CAD and PAD who also have diabetes, their absolute event rates were very high, and their absolute risk reduction was also substantially, significantly higher in this context. Now, finally, Dr. Eichelboom and Bhatt and myself and a few others wrote this paper. Should be out now. It's just a way of thinking about who are the patients that are COMPASS eligible. And as you can see, at the tip of the iceberg are the highest risk patients with CAD and PAD. And then as you move down the list, you see that those are the patients who actually start deriving greater or lesser benefit overall in terms of absolute terms, but the bleeding risk is actually quite consistent. So efficacy increases with polyvascular disease, and then on your right are people with the continuum of risk. I think one very important message is here, and this may sound like a cartoon, and it's very simple, so I apologize. There's no advanced statistics here, but it's a way for the doctors to think about who is my patient. And if you look on your right, it's like an amplifier, right? You know, I think our kids don't have these kinds of toys anymore, but when I was growing up, we used to have these kinds of toys where you actually had a radio and you actually turned things on and you turn volume up and you turn other things down. Now they have everything on your phone, but think about the two populations, the CAD and the PAD. Those are your big populations to get into COMPASS. And then all of those small knobs are the fine tuning that helps you then refine the people who really derive a greater benefit. So people with diabetes, people with CKD, people with heart failure are the ones that derive greater benefit. And I'd like to finally remind our cardiologists about how to navigate the conversion. And that is that what's a practical algorithm to go from DAPT to DPI? And that's listed here, that in a patient with CAD on DAPT after coronary stenting or post-MI, evaluate their ischemic risk. And if the ischemic risk seems to be driven by a lot of metal and stent, then continue DAPT. If the ischemic risk seems to be driven by PAD and recurrent events and heart failure and CKD and atherothrombotic burden, then consider stopping DAPT and initiating a low-dose therapy. So I'm going to stop here and say there's various ways to engage the pathway of dual pathway inhibition with coronary disease, PAD, CAD or PAD or post-DAPT. So to summarize, colleagues, thanks again, Dr. Mahmoud, for this opportunity and all of our distinguished chairs. Congratulations to you on the launch of low-dose, on the launch of Rivaroxaban generic, or Zarlan as it's called. And this has been a remarkable story of great success for stroke prevention, for venous protection, and also for vascular protection. And I encourage you to use this therapy in keeping with your local label and based on the recommendations from key leaders like the chairs that are on the line at the present time. Let me hand this back to you, and maybe we have a couple of minutes for questions.
Yeah, thank you, Dr. Verma. Thank you very much for your very interesting lectures. So I will start for a couple of questions. First question, Rivaroxaban therapy in post-PCI patients with atrial fibrillation. This is in the Pioneer Atrial Fibrillation PCI study. They are used a 15 milligram dose. Why do the guidelines recommend 20 milligram instead of 15 milligram?
Yeah, it's a very good question. I think the primary reason for that is that the trial was small, and most of the data on efficacy has been derived by 20 milligrams. The bleeding efficacy is what drove the outcome of the trial. So it's safe at 15, but to ensure that the efficacy with respect to stent thrombosis, with respect to recurrent ischemic events is maintained, and also in many ways to prevent the confusion that exists around the various doses. A dose of 20 milligrams was used. In Canada, we do have a subtext that does allow 15, but as you know, in Europe and other guidelines, it has been maintained at 20. Give me 1 second. I just want to make sure the operating room is not calling.
Yeah, okay.
It's a good lecture, Mahmoud. I think we had some, Mahmoud, we had some questions from the audience, by the way. I don't know if you noticed them.
I have a couple of questions. Let's finish my questions first, and then we'll go. Yeah.
I have about 5 minutes.
Yeah. Okay. Next question. As you know, the use of Rivaroxaban in stable angina or in peripheral arterial disease, according to the results of Composite trials, show an increase in the risk of bleeding. At the same time, it decreased the risk of MACE. Can you please explain the net benefit of Rivaroxaban in these cases?
It's a wonderful question. So there's a bleeding risk. The bleeding risk is not from a fatal bleed or an intracranial bleed. It's mostly GI bleed. The net clinical benefit, which looks at death, MI, stroke, minus the GI bleeds, is still highly statistically significant in favor of low-dose Rivaroxaban and aspirin. And therefore, guidelines have strongly endorsed that. And I would recommend to our colleagues not to be concerned about that per se. Please also remember that the bleeding is a sign in most cases of an underlying cancer as opposed to the molecule. And finally, please be reminded that the bleeding is front-loaded when it does occur, in that, again, if people bleed in the first year, then they tend to bleed more. If they don't bleed in the first year, then they actually don't bleed at all.
Okay. Do we have a time more, or how many?
I can take a couple more questions. I can take 2 more questions from you for sure.
Okay. How do you manage patients with antiphospholipid syndrome, either with the deep vein thrombosis or atrial fibrillations? Can we use NOAC in these cases, or?
Yeah, it's this was the topic of a recent study that was done, and the answer to that is no. It just doesn't seem to be associated with a benefit in that regard. And maybe it's the autoimmune nature of the strategy. Maybe it's the mechanism of coagulation that is being stimulated. As you know, also in valvular AF, we can't. So I would, at this point in time, personally, I don't use it in that setting. I'm not sure what your practice is, but that's probably the safest thing.
The same, we don't use it. Yeah, okay. Okay, we have one question from the audience. In COVID-19 patients, when I have risk of pulmonary embolism, can I use Zaralan? And when compared with Mixnat, which is safer and has less risk of bleeding? This is from Dr. Usama Ahmed Rida.
Yeah, so I don't know the answer to that. As you know, there's no trial data to inform that. But there is a study ongoing of COVID-19 using Rivaroxaban at the present time. And that is because one of the key features of COVID-19's biology seems to be a prothrombotic effect. So I think it's a reasonable rationale to be testing that in that context.
This is a question from Ahmed. Heparin or Rivaroxaban in long-term prevention of thrombosis in a cancer patients have better outcome or not?
Don't know the answer to that definitively. I think there's real-world data that suggests that its equivalent bleeding risks is certainly seem to be lower with NOACs compared to heparin per se in those contexts, but there is no large trial data to inform us on that. Listen, Dr. Mahmoud, I think I have to run to the operating room. I apologize.
Okay. Thank you very much.
It's my pleasure to be with you, and congratulations to all of you on this molecule. I look forward to seeing you in person and having a meal with all of you, particularly my dear friends here on the line. And Dr. Hadi, say hi to the family, and wonderful to see you.
Thank you.
Okay,
bye.
Bye.
Okay, thank you very much.
Good luck. Good luck.
Thank you. Appreciate it.
Good luck. Yeah. So we will start now the second part.
Dr. Mahmoud, can we just answer few questions from the audience. If you can help us, you and Dr. Hadi, to answer the questions.
Which one? Regarding patients with atrial fibrillation and acute coronary syndrome, what do you prefer, doctor? Especially after the good results from Augustus trial from Rivaroxaban. So, what do you think, Dr. Hadi?
Well, Dr. Verma said something very important, and I think it's a great message for everybody. Remember what he said. That's why I like this guy personally. He said, when you look at the data of DOACs, we are not in the marketing business of certain molecules. We have to know the data and not market the molecule. That's what he said. Remember that. And I think that the Augustus trial, the Redual, Pioneer, they all showed good outcome. So I would not really try to make a statement about which of which is better. I think you have to get used to a molecule, how to use it, its dosing and its interactions, its side effects, and go with that. That will be my answer. There is nothing there to convince anybody that there's a superior molecule over the other in this particular indication. Dr. Iyad is with us, and I'm sure he would agree with that too.
I totally agree. You're right.
Okay, we'll finish the questions, huh?
There was a question, Mahmoud, about strokes, when to use DOACs in a large stroke.
This depends. If you are talking about a small stroke or medium size or large size. Large size usually you after 2 weeks. If you have a medium size of stroke, it takes around 1 week. If it's small, maybe immediately or within 24 hours. This is what I know. If you have any idea about that.
No, it's true. It's true. But you know, like what we have a heart team in our cardiovascular type of practice. And when it comes to strokes, I think there's another team. It's a cardio-neurology team. You have to coordinate this with your neurologist. And, you know, we follow guidelines, but we also have to look at individualized type of treatment depending on this. What do you think, Ian?
That's true. I always ask the neurologist actually to clear for me when to start using any anticoagulant post-stroke. I mean, you know, there is always some risk of transforming an ischemic event to a hemorrhagic event.
Hemorrhagic, yeah.
Sure.
Okay. Bassam, is everything okay? We'll finish this part. We'll go for the second part.
Yes. Let's go.
Okay. We'll start
Thank you.
To the second part. Alan, Dr. Iyad. We have Dr. Iyad from United States. Dr. Iyad Azam. أهلا وسهلا فيك.
يا هلا فيكم.
بالتلفون ورتبنا الأمور وإحنا حكينا إحنا راح يكون في عنا many lectures how should I treat CAD conference. بنحب دائما تكونوا موجودين معنا. طيب خلينا نعمل طبعا we have Dr. Hisham Al-Mahmoud from Palestine, interventional cardiologist. Dr. Hadi Abu Hantash, الكل بيعرفه, consultant interventional interventional.
He muted himself.
دكتور محمود بطاح ساعدنا.
Hello. Dr. Hadi intervention. He is a consultant interventional cardiologist, and we'll start second part of the how should I treat.
Dr. Hisham.
Just 1 second.
He is muted, Mahmoud.
Just 1 second. Is that clear? No? شايفين واضح هون ولا لا؟ دكتور هادي.
Yes sir.
واضح هون ولا لا؟
ما فيش شيء مبين عندي.
طيب اوكي one second. One second. Okay, share.
هو هشام سامعنا؟
Just 1 second. Okay.
انت محمود بدك تحط لي presentation.
Yeah. What is دكتور هشام؟ دكتور هشام. خلينا نتصل معه لهشام.
ممكن عنده مشاكل بالكونكشن لأنه هي لفت.
والله؟
يس.
هسه بحكي مع التليفون.
هي اجا.
الو.
والله حاطط اغنيه حلوه. طب خليها.
حلوه. الو. ايوه، وينك يا دكتور هشام؟ وين؟ طب وينك انت؟ اطلع معنا الان. اعمل من شو اسمه، من الايميل. طيب احنا في عندنا good sessions اليوم، راح يكون very interesting. We have 2 cases. ننتظر الدكتور.
ابعت له اللينك على الواتساب، يمكن اسهل له كمان يا محمود.
هو دخل على الايميل، ف
اوكي.
no problem with that. طبعا احنا عندنا اخر الشهر هذا راح يكون عندنا مع مصر، فلسطين، جوردن، مع يونايتد ستيتس كمان. اياد اذا بتحب كمان تشاركنا انت، اما بحالي او تكون باناليست معنا او تكون مودريتور معنا، بالعكس بتشرفونا يعني.
الله يسلمك.
الدكتور ياس راح يكون موجود معنا. في عندنا حالي ل interesting case يعني راح يكون ST elevations MI, what to do, multivessel disease, to do one lesion, calibrate lesion or go for other lesions. This is one case. وفي عندنا كمان case من Egypt, big clot راح نناقش فيها. فبنحب الكل يكون موجود. دكتور ياس بتوقع هو معنا بسمعنا، راح يكون معنا آخر الشهر هذا. نستنى الدكتور هشام. دخلت يا دكتور هشام؟ دكتور هشام أين أنت؟
لسه ما دخل.
ما دخل؟ طيب
نقدر نكمل على كيس ثانية قبل ما يجي؟
دكتور أنا رأيي كالتالي. أنا رأيي الكيس هم أصلاً استشاروك بها دكتور هادي أبو هنطش.
استشاروك على الكيس. I present whatever I know about them.
طيب هذا الكيس a 38-year-old male patient presented with recurrent attacks of chest pain. ECG normal. أنا طبعا ما عنديش تفاصيل على الحالة. He did a CAD for him and this is right coronary. أنت معنا؟ وين معنا؟ وين بدنا الصورة؟ وين أنت؟ حتى يعني مش شايفينك إحنا. وين؟ لا أنت بدك تطلع عن طريق الإيميل. طيب بس مين في من التكنيكال ممكن يساعد الدكتور؟
بطاح.
نعم سامعك.
تقدر تتواصل مع الدكتور هشام لو سمحت؟
اوكي
شكرا. العب الصورة الثانية. طيب. محمود
خلينا احنا على بال ما يكون this is right coronary artery and this is LAD circumflex. يعني anything here يعني. طيب الصورة اللي بعدها.
there is something يا محمود.
yeah بس هذه واضحة جدا يعني.
okay.
How would you manage؟ يعني definitely we have this is a bridging. So how would you manage? A, medical therapy. B, PCI. Stent to LAD. C, surgery. So what do you think, Dr. Iyad?
So this patient presented with chest pain. He said he on any medical therapy.
هي دكتور اجا. دكتور وين راح؟ اختفى. ميوت من عندك.
قل له تعال ميوت. تعال
ميوت عامله انت.
ايوه اوكي
طيب نبلش بالحالي ما دام جيت. يلا هي بلشنا بالحالي.
اوكي يلا.
تفضل دكتور هشام يلا.
First, as you said, this is a 30-year-old male patient, business worker. He's an active person. I know him very well. He is presented to me for more than once with recurrent chest pain, with exertion, or even with any stress, with any anxiety moments or something like this. I have done to him exercise test. He got frequent PVCs and shortness of breath without obvious ECG changes. I stopped the test because of frequent PVCs, because as we know, it is a reason. They appear at a reason to consider the test positive. Anyway. He got chest pain, but during that he got chest pain. I took him to cardiac cath, and that was the picture. As we see here, the mid segment of the LAD long segment bridge, myocardial bridging with compression during systole, and he got this picture. What we have thought to this patient. First, we put this is the picture that I have sent to Dr. Hadi when I did it. I have done it a few days ago, maybe 1 week ago, not more than that. And I put him on intensive therapy with beta blockers and calcium channel blockers.
دكتور هشام خلينا احنا نبدا نقطه فيها. نبدا بالنقطه هذه. How would you manage؟ طبعا هذا الباناليست medical therapy PCI stent to LAD and surgery. ونرجع لك دكتور هشام. رح نرجع
طيب
لك.
اوكي.
دكتور اياد, what do you think?
Yep. So
أول شيء, do you agree this is a bridge or
yes,
not?
absolutely. Yeah, there is
يعني
a significant.
بتحلف عليها this is a bridge, yeah?
أكيد. Yes. So I mean, medical therapy is first line of treatment for for all the patients actually with myocardial bridge. One of the things I would be, that I learned during my fellowship a long time ago is that when you have frequent PVCs during stress test, especially if it's a treadmill stress test, try to look for the morphology of these PVCs, so to try to identify where they're coming from. This might have prognostic significance. So PVCs coming from the anterior wall because of that bridge would have right bundle morphology, and then you look at AVL lead and see whether it's positive or negative. So this is the first thing. Second thing for myocardial bridge is to look for family history of sudden cardiac death. I would take it more seriously if there is anything like that, and also a personal history of syncope. If all these things are negative, I'll be extremely happy with medical therapy and see how he's doing in a few weeks without nitrates.
Dr. Hadi, what do you think?
I agree with you, and I think this is, it's definitely a bridge. Reviewing the literature to call it a bridge, because a bridge can be found up to 60% incidentally in angiograms, which we do, and not all of them are obstructive dynamic bridges. We have to define that. This is an obstructive dynamic bridge. It obstructs the lumen more than 60–70% during systole. So it's a dynamic obstructive bridge. Reviewing the literature again, everybody would agree you are better off with maximal medical therapy on those patients, unless, like what Iyad said, that there's a previous survival from a sudden cardiac death, documented sustained VTAC on treadmill, etc. Something which puts this patient at higher risk of death. Otherwise, I will go with beta blockers, lower the heart rate as low as possible for this young patient to 55, 60. If that does not work, to lower it, you always can add the calcium channel blocker, which can help you out, and I would go with that. And I would try my best to avoid in a 38-year-old gentleman putting a very long stent in this area for two reasons, Al-Hayya. One reason is you will need at least, I would say, 33, 38 millimeter stent here to cover the edges. You have to remember that the proximal edge and the distal edge have a low shearing force, while the one in the middle has the highest shearing force. And what's funny about it, which is very not well understood, that atherosclerosis occurs in the proximal edge, while the distal edge does not have it. But either ways, you will need a long stent. And having a long stent in this area for a 38-year-old male, almost 99% will preclude him from putting a lima in the future. So I would maximize medical therapy and see what happens to my patient.
Okay, Dr. Hisham.
Yes, I agree with my colleagues, but concerning the wall shear stress at the proximal, just proximal to the bridge, is an obvious finding in IVUS and in FFR. For me, I will follow the patient clinically and I will see what's happened. And concerning the cabbage, the second choice is PCI, the third choice is cabbage. But they prefer, according to a study, they prefer saphenous vein graft rather than lima. I am following up this patient. He's just only 1 to 2 weeks on medical therapy. I will follow up and see, but I for the safety and for the what the patient prefer, a patient like this in this age in our population, not easily to convince them to go for open heart in the 30-year policeman, active policeman. I think if he will not get benefit from the oral medical treatment at maximal doses of calcium channel blockers and beta blockers, if the patient will insist that he doesn't like cabbage, I would go for PCI with drug-eluting stent.
Do we have guidelines for that, for bridging? When you go for stenting rather
actually,
than... do we have?
No.
We don't have.
Actually, I have seen many trials. They no big number of patients in the trials, 15 patients, 11 patients, like something like this. And in some studies, for my patient, I have five patients with myocardial bridging. I have stented 3 of them about 18 to 19 months ago, and they are still doing very well. PCI has changed their quality of life actually, and they are grateful and coming regularly to me, and no any problem, no any complaints, no anything. You know, the result here, what we are expecting, that when we evaluate the patient by FFR, by IVAS, by something like this, we will see the depth first of the, if more than 5 millimeters, they are not even fit for surgery or myotomy surgery, or according to the situation of the patient, quality of life will do better after stenting. He will go for, I will go for PCI.
Okay. Dr. Iyad, how you assess when you say this is severe, when you say this is a mild, when you say this is moderate? Depends on the deepness of the coronary, or what? Dr. Hisham, he said that's if the depth of the coronary is more than 5 millimeters. What do you think about that?
Sure. So what we do here is you know, to determine whether you know, surgery would be or should have a better outcome or not. We start with cardiac CT. So this is far better than any other modality, in my opinion. You know, to let you know, and the surgeon also, how deep the bridge is. When it comes to stenting, I believe, you know, the longer it's like, you know, all other disease. The longer the stent is, the higher the rate for in-stent restenosis. What I'm worried about, if this is a very deep bridge, is whether the stent will fracture in the future, or even worse, you know, rupture of the artery, because this artery is deep in the muscle, and I saw it before my eyes, you know, with one of my partners years ago. That artery just opened up. I mean, you can get a left ventriculogram when this happens, and you don't have a long time. I mean, luckily that patient survived, but it was, I was 1 year out of practice when I saw this, you know, with one of my previous partners. So how I would evaluate something like this, you know, if we determine that medical therapy is not enough, if it's a long, if the patient is young, if the artery, the segment is long, I prefer a surgery for someone like this. If it's a deep segment, more than 5 millimeters, as it's said, myotomy becomes a problem. At that time, probably a bypass is more appropriate and is easy. I mean, which cardiac surgeon doesn't do a great job, you know, with just single vessel bypass? If the patient is a high-risk surgical patient or inoperable, if the segment is less than, I would say, like 20 millimeters, I would use a stent.
Stent for that. Okay, Dr. Hisham, you said that SVG is better than Lima in this case?
Yes, according, yeah, I have seen in a study that they say that they prefer SVG to rather than Lima.
It's a study which has, Hisham. It's a study which was observational, and I agree with Hisham. They raised this point. Something which is important for all of us to know, that we all think that the dynamic obstruction is only during systole. Actually, yes, it's true, but it's not all of it. It extends it through diastole. And that's what makes the failure of the Lima likely, especially early failure. And that might favor the saphenous venous graft, as our colleague Dr. Hisham mentioned. The only problem, like what Iyad mentioned, if you put a stent there, this high shearing force in the middle area and the high atherosclerotic burden in the proximal edge puts this at a very high risk of instant restenosis.
Yes, especially because it's a long
which
lesion.
makes it even more difficult to treat.
Yeah.
I mean, if I want not to encounter an ISR in my life, this is an ISR I don't want to treat. An ISR in a bridge, because that's really a very difficult one to deal with. So, and surgery, like what you both mentioned, I mean, we're not talking about bypass only, we are talking about myotomy. Myotomy, if any of our surgical friends are with us, they will tell you it's not their favorite to do.
أخطأنا, it's my fault, ما جبنا الجراحين معنا بصراحة. It's my fault.
بس محمود هذا كتير مهم. الجراحين they don't like myotomies, by the way. They really don't like it a lot. Especially as Iyad and Hisham mentioned, the deeper it's invaginating inside the myocardium, the more difficult it is, and they might get into more trouble doing it. And the longer the bridge, it becomes even more difficult to do it. So
yeah.
طيب بس ممكن تلخيص دكتور هشام انه بهالحالة حالتك هذه انتو you did يعني you give the patients medical therapy, beta blockers number 1. Number
Now
2,
he is on beta blockers at maximal doses, and I will observe the patient. I will see if the beta blockers will not be enough to reduce heart rate to the target number what we want. I will add.
What's your target? What's your target?
50 to 60 heart rate, not more than 60.
Okay.
And I will see the response to of the patient, what will happen with him concerning clinical presentation, clinical symptoms, clinical complaints, and we will discuss the case with the cardiosurgeons. As Hadi said, they don't like to go for myotomy because they don't know the depth of the case. I have seen in the literature that cases of ventricular rupture, ventricular perforation, many complications.
Okay.
We will see
what if your patient is coming with acute anterior MI and you have this case? What would you do?
Yes, if STEMI elevation,
anterior leads, what would you do?
I will do CAT. I will go for CAT first. If this segment is occluded,
we are talking about this patient.
This patient, yes, I am talking about this patient. If this segment occluded of the LAD, this segment tunneled LAD, I will recanalize without stenting.
The same patient. You have the same.
Yes, I will I will not leave the LAD occluded until with losing time with to let the left ventricular dysfunction happens.
So you will go for PCI.
I will recanalize without stenting.
Without stenting,
Yes, without stenting. I will discuss with the surgeon and we will see what we will decide at that time.
دكتور إياد، يعني هذا المريض اجانا وصار في عنده anterior ST elevation. طبعا ما في كلوت، يمكن اوتولايسيس، راحت الكلوت whatsoever medications، بس انت عندك يعني it's clear cut this is an anterior MI. What would you do?
Okay, if it has recanalized and Sure. If it has recanalized and I have the lumen, I still will leave him. If it's still 100%, I advance a wire, I push the clot down, and then I see a bridge. True. I mean, there are many ifs here. So is he in cardiogenic shock? If he's in cardiogenic shock, I will use either impella or balloon pump and balloon, but not 1-to-1 size. I would say probably 2, or just to recanalize and see what happens. If I'm able to abort the MI and get him more hemodynamically stable, I still will stop and leave him for surgery.
Yeah.
If absolutely not, and I have to use a stent, what I would do is use a drug-coated stent, but before I deploy it, I always would tell the staff, get me the covered stent ready. So I decide the size of the stent, of the covered stent. I have it in hand of one of the staff members closed, but out of the package. And I tell them, when I say, give me the covered stent, there's no question about like, okay, what size, and go to another room and get it. When I say covered stent, it's open in like a second.
Okay, Dr. Hadi.
Well, I tend to agree with that. Actually, Iyad and Hisham and Mahmoud, when we had the absorbed stent 5 years ago, we were very excited that it might be the dream treatment for myocardial bridges. I'm sure you all agree, just thinking about it's putting a scaffold there, treating the issue, having it stay open, and then it dissolves. But unfortunately, we know that the other than the absorbed thrombosis rate, the other thing which is not fitting in is the radial force of it. It might not undertake this radial force in the middle of the bridge. But I agree with you, if ST elevation comes in totally occluded, I will recanalize. I see a longer bridge like this. If I have a TIMI3 flow, a myocardial mush, which is okay, patient stable, I'll leave it alone.
Okay.
One more point, just commenting on this angio. If you take a closer or a close look at the diastole, that segment, I still see it does not expand, and this makes it harder for the surgeon actually. So probably for this patient, if the decision is made to move with surgery, probably this patient would benefit from bypass and not myectomy.
Okay, which of the following is contraindication in this case? Beta blockers, calcium channel blockers, nitrates, aspirin, rivabridine.
For me, a question for me?
لا for دكتور هادي.
Okay.
ان شاء الله يا رب ما تعرفها بس.
هشام انت هو عارف انك عارف الجواب. Well, I think anything which will dilate the entry point of the bridge is going to make your life horrible. So nitrates, I would avoid it. Actually, dihydropyridine calcium blockers might not be a great idea either, by the way, for the same reason. So yeah, I would not.
But the only contraindicated is nitrates in this case. Okay, we go for the next case. Dr. Hisham.
Yes, she's a lady of 55-year-old, non-hypertensive and diabetic. She presented also several times with chest pain, recurrent chest pain, exertional chest pain. ECG showed only anterolateral T wave, not inversion completely, flatness of the T wave. But clinically, it was highly suggestive. That's why she's not able to go for exercise test. I have taken her to cath lab, and this was the finding. The LAD also, as I said, I have 5 cases of myocardial bridging. 5 of them are the LAD is involved.
Area?
Yes, in this area. Because it is a short lesion, and the patient's 55 years and hypertensive, and as we know that hypertension, one of the pathophysiological diseases causing pathophysiological changes that could induce symptoms of myocardial ischemia in previously asymptomatic patients, and they can exacerbate the supply-demand mismatch imposed by the bridge segment. And it is a short one, and she is suffering. I preferred actually to go directly to stenting, and it is almost 18 months from bridging, from stenting, and the patient is doing very well and no complaints. Right. I have stented this patient.
خلينا قبل ما تكون, how would you manage, Dr. Iyad?
I'm sorry that I said.
How would you manage this case?
So agree. Medical therapy, if still the same. If this fails,
the same as the previous one, right?
Yeah, I honestly, the picture, the video was not playing the right way here on my screen, but
okay, I will show you a video.
What I
Mhm.
what I wanted to say, and I did not mention it, that she is hypertensive and she is on calcium channel blockers and beta blockers for the treatment of
I see.
hypertension already.
So she is already on medical therapy.
Yeah, she is already on medical, yeah.
I see. Yeah, I missed that point.
And
So
still having symptoms.
And this is the area. This is the area of bridging, and this is the area of bridging. It's focal, maybe here. Yeah.
Yeah, focal. Yeah.
Yeah. Okay. How would you manage, Dr. Riyad?
So, there was no stress tests, right? Because of the severity of her symptoms, and she's on probably maximum tolerated therapy. I still would IFR that lesion.
FFR, Dr. Hadi.
Yeah, FFR, IFR, yes.
Yeah, I think I would just say the same thing again. I mean, she failed medical therapy. She's not a high-risk patient for events. I'm not quite sure I will be enthusiastic on putting stents either, though it's a very short segment. I would like to use ancillary imaging, you know, like what Iyad probably would agree with me, just to look at it, see by IVUS, document the ischemia by something, at least an FFR, and see what kind of information I get.
Dr. Hadi, could you explain why IVUS in this case?
Well, IVUS can, first of all, delineate if there is any extensive atherosclerosis in the proximal edge, which can obligate you to cover, which is an important item. It can give you the depth of the myocardial bridge in terms of how deep it is seated in the myocardium, which might also make you be aware that the high likelihood of getting in trouble, like what Iyad said, like rupture or perforation. So it will be very helpful. And what's more helpful for IVUS is not the pre-PCI, it's post-PCI to make sure that you got good results, good position, and all of that. So,
okay, we'll go to the next slide. What you did, Dr. Hisham, tell us.
This is a young man of about 40 years old.
No, the same patient, the same patient.
The same patient. I have,
yeah.
You know,
just explain to us what's going on.
For this patient, she's diabetic, she's hypertensive, she's obese, and she is on maximal therapy for control of hypertension, including CCBs and beta blockers, and she's symptomatic. In spite of that, she's symptomatic. For improving the quality of life of the patient, actually, and it is not a long lesion; it is a focal lesion, and symptomatic. I preferred, and I decided to go directly to PCI, and it was easy. It was straightforward, and improved the quality of life of the patient. And I'm happy with the result, actually.
Dr. Riyad, do you agree with him, or you maybe think about surgery for this patient?
No, I don't believe surgery is necessary. So my point is to document that this is a physiologically significant
by doing FFR.
Yeah, by doing FFR or IFR, and after that, I totally agree. You know, as I mentioned before, you know, if my opinion is that if the lesion is less than 20 millimeters in length, just go ahead and stent it.
Dr. Hadi.
I have an emergency patient in the emergency room. I was sending them a message. I'm sorry, Mahmoud. Tell me.
Okay. Do you agree with what did Dr. Hisham?
Did he do pre-dilatation, Mahmoud?
Hisham.
No.
Direct stenting. Yeah.
That's something which I would not do, my dear, wonderful friend Hisham, in this bridge. And even if it doesn't have calcification, I'll tell you why. I mean, I don't do a lot of bridges for sure, but theoretically, I would put a balloon in, make sure that there is no major indentation in the balloon before I put the stent in, and see how much force I would need to open it up with. I don't know. I would be worried a little bit about the stent, the shearing force, and how good of an opening I will get. I don't know what Iyad thinks.
It's a good point. Yeah, it's definitely a great point, because you know what, if one primarily stents and then there is some residual stenosis, you are in a bad position. You can't go with high pressure or non-compliant at very high pressure. You know you're stuck and you're done at that time.
Dr. Hisham, you did a great job in this case.
Absolutely.
So thank you very much. شكرا للجميع. أبدعتم. شكرا لبلسم. أبدعتم كشركة راعية. وبنتمنى احنا دائما نستمر بالكونتينيوس ميديكال اديوكيشنز. انا لو بتلاحظوا احنا دائما بنحط فلسطين، وراح نضلنا بكل حالاتنا نحط فلسطين معنا. طبعا المره الجايه احنا راح تكون حفله مع جامعه عين شمس. احمد كامل اذا بتعرفوا، دكتور هادي، يعني عندي حالتين من عندهم بيرفكت excellent cases. يعني الدكتور إياس راح يكون معنا ديفينتلي الاسبوع مش الاسبوع القادم، اللي بعد القادم. دكتور إياد، احنا بنحب دائما تكونوا موجودين معنا، وانا خبرت بهاء انه يكون موجود معنا، وكل الاطباء احنا عاملين برنامج بالتليجرام وبدنا اياكم كلكم تكونوا موجودين معنا. دكتور هشام ابدعت مره ثانيه.
اشكرك.
ابدعتي والمحاضر بيرفكت. يعني انا فيرما هذا بصراحه مبدع بس هي بيشتغل بالكارديو، هي كارديو سيرجن رايت؟
يس.
بس مبدع بصراحه، يعني مبدع حقيقه. الله يعطيكم العافيه. في اسئله من الاودينس؟ حدا حابب يسال اي سؤال؟
شوفهم يا محمود اذا في شيء.
شوف في اسئله.
الدكتور علي ابو مؤمن بعت لك، بيقول لك may I suggest in a hybrid theater laparoscopically do myotomy while the cardiologist close the LAD to do more localization and see the result. Wow. Okay. What do you think, Mahmoud and Iyad, of this? Dr. Ali, طبعا, he's our colleague, also surgeon with us.
شو السؤال؟
شفت السؤال محمود؟
لا انا وين السؤال؟ هو
تحت بالاخير دكتور محمود.
بالاخير.
It's a good question, and I don't know the answer for it, by the way. I don't know if Dr. Ali can tell us if he did it before بالمدينة أو لا. I don't know.
أنا مش شايف.
مين اللي حاطط السؤال؟ لأني مش قادر أشوفه.
الدكتور علي أبو رمان.
وينه؟ أي واحد هذا؟ أنا
السؤال جاي نمبر، فيش نمبرز هنا.
فيش نمبرز.
فيش نمبرز عشان أقول لك. let me see. على أول صفحة من the questions. If you go down, you will find it. Did you see it, Iyad, or you can't find it?
No.
The questions, the question box, the one which says open, it says 17 there. Is that what you have? No, it's on the same screen I have it. Yeah, it says 17 in the same page. In the first page, if you scroll down, you will see it in the bottom of the first page. But anyways, it's an interesting question. I wish Dr. Ali Abu Man can tell us if there's an experience at King Hussein.
إذا ممكن إحنا ممكن ندخل الدكتور علي أبو رمان يكون موجود معنا ويطرح لنا فكرته.
Sure.
ممكن ندخله. ممكن بلسم أنا مش الهوست.
ممكن يدخله، بس تقدر تبعت لي الإيميل تبعه بليز.
Oh, I don't know.
لا. طيب
ممكن تقرأه دكتور هادي؟ ممكن تقرأ السؤال مرتين؟
أنا مش شايف. اقرأني يا بلا السؤال مرة ثانية.
السؤال بما معناه هنا اللي أرجع له. دانت وين هلا راح؟ May I suggest in a hybrid theater laparoscopically do myotomy while the cardiologist close the LAD. يعني هو بيعمل myotomy وبيخلي الكارديولوجيست close the LED more to do more localization and see the result. That's exactly how we say it. Interesting.
I don't know the answer at all.
I don't know either. بس يمكن يكون الدكتور علي عملوا حالات زي هيك في المدينة. That will be interesting.
كيف يعني close؟ يعني inflate a balloon and keep it
مش والله أنا زيك دكتور إياد. It's quite interesting.
The question is not clear. What does he mean by closing the LAD by stent or what?
I don't know. يعني الدكتور علي لو إنه معنا كان جاوبنا، أنا متأكد يعني لأنه it's interesting السؤال. يعني هل ممكن إنه في المدينة عملوا هذا الشيء أو لا؟ I don't know. هيني أنا طلبته يا شباب إذا هذا بيهمكم.
Dr. Hadi, Dr. Mohammed, have you seen in your experience any cases have undergone myotomy surgery or?
دكتور علي كيفك؟ السؤال اللي سألته لا معلش تعيد. انا حطيتك على السبيكر باي ذا ويز والكل سامعك حبيب القلب. تعيد لي كمان مره، قول لي شو السجشن دكتور علي.
هذا اقتراح مني. انا سابقا الجراحين عندنا مشكله في تحديد موقع البريدج يؤثر على الجسم.
اوكي.
عشان ياخذ حاله وما نرجع للجديد.
اوكي.
ونضطر نسوي له جراحه.
اوكي.
انا هذا الثياتر الكاريوتيست تنفخ بالونه اوكسجين على النادي.
اوكي.
عندي كومبوسيت النادي تحت.
صح.
فبتحمل اني ادخل انا اي شيء تحت النص من دون ما افتح النادي وابص النص. بعد ما اخلص انا شغلي برجع ويعطي راي. فبشوف انا حليت المشكله ما حليتها. ما حليتها بحط المنطقه الموجود فيها تغير حتى افتح لا بشوف في بيتي انه ما فيش بيتي ومتكافئين في ان احنا نسوي هاي العمليه. وبالنسبه للاوبشن اللي حتى الزميل انه ليه احسن ليه ما احسن ليه ما كان ضد الفلو يقول لك الفلو مش نفس البين اللي كان ضد الفلو هذا
اوكي.
انا هذا اقتراح عندي انه هذه الطريقه احسن من انه في سبب ان ما تحط نقطه السن لانه النص الموجوده ما راحت ممكن ترجع تتعادل في السن الموجوده وتتكرر مع الوقت. تسوي كل كومبوزيت.
اوكي. عندكم حالات عملتوهم في كينج حسين ميديكال سيفن؟ اوكي.
كان عندنا فتره متكاب تعبد المدنيه ونزاحها. لما تفتح تحكيها عشان شرط بسيطه جدا. هي ديبريشن شعبه سهله جدا مش فيها برفايزيشن.
والله شكرا لك دكتور علي. احنا مشكورين جدا انك جاوبت التليفون والجميع بشكرك على المشاركه. والله شكرا دكتور علي. شكرا.
احنا المره الجايه
بلسم بقول لك علي ابو رمان ايش؟ علي ابو رمان.com. شكرا دكتور علي. شكرا.
احنا تقريبا انهينا السكشنز تبعنا اليوم. نلتقي نهايه هذا الشهر والله يعطيكم العافيه. ومره ثانيه شكرا لبلسم لدار الدواء على هذا الفرصه الحلوه اللي عملناها مع بعض، وعلى البروفيسور اللي اجى سودو من كندا. Subodh Verma.
Thank you for this fruitful session. جد بسطنا بوجودكم جميعا معنا. Thank you so much.
Thank you all.
الله يعطيكم العافية ونراكم.
شكرا دكتور
هشام. يعطيكم العافية. العفو دكتور.
يعطيكم العافية.